work to make Cass Clinic work properly. Are they supposed to be present for this meeting? Because it kind of feels like it would be helpful for them to be there, but at the same time, they say that apparently there's a meeting at 1 o'clock. Is that a different meeting that they're supposed to be a part of?
Yeah, so they will be attending at about 1:30, I think, Kim, is that correct?
That's correct.
Yeah.
From my understanding, they're just wrapping up their day with the patients, but
Correct.
if they're available, whenever they're available, they can essentially jump on and then we can discuss.
Oh, no, they're still busy at work, apparently.
but yeah, right. I hear the laughter.
Yeah, exactly. They'll get on as soon as they'll be on shortly, but I'm on.
Okay. Perfect. Excellent. Okay, so before we get into the nitty-gritty, I just want to make sure that there isn't any workflow changes since the last time we spoke, any new CAS tech or no new physicians who are going to be your regular staff in the CAS clinic.
Nothing new.
Excellent. And there's no trials or anything that's moving forward.
Not that I'm aware of.
Okay, excellent. Okay, so just so that we're all on the same page, I'm just going to be comparing what we know about the CAS Clinic current state and comparing it with the future state. And so that's just so that we can compare and you can decide which option would be best for you in the clinic. So current state, we know that the referring provider is most often coming from the ED or inpatient units, and they would call the ortho provider on call if they see a patient would benefit from being seen in the CAS clinic. If the ortho provider determines that this patient is appropriate, it would be the referring provider who faxes the referral order to the CAS clinic. And the clerk, RE, would be receiving this via fax machine, and they would book and confirm the patient, confirm the appointment with the patient. So that's current workflow. Based on our last discussion, one of the main concerns is that occasionally the ED docs may send this faxed referral directly to the CAS clinic without a discussion to ortho providers. So recognizing this concern, plus recognizing that these referral orders should be booked sooner rather than later because they're coming from ED, and wanting to minimize the number of steps required in order to do so is going to be the following future state internal workflow. So that being said, you can maintain your current mode of communication, which is telephone, and instead of the referring provider, it would be the ortho provider entering through Cerner Power Chart. So the rationale for that is mainly because the clerk who receives this referral on their scheduling app book in Cerner, they're continuously monitoring the referral list. They see that the order is written by the ortho provider, then can be confident that a discussion has taken place. If by chance the clerk sees a referral on their request list that's not made by one of the 8 or 7 ortho providers, kind of gives her a red flag that perhaps this discussion did not take place, and if it would be best or they would connect with you in whichever mode, which is effective, email, message center on Power Chart, in person, whatever is best to see whether this patient is going to be accepted and booked into the clinic.
So I guess I have to see what that means, because me having to fill a bunch of things out to send it to clinic, I don't like that idea at all.
So for, I'll show you in the demo. It's more so that, actually, maybe I can just show you right now, just so that there's a better understanding.
Because the referring physician is going to refer the paperwork, the image, like there's things that they're going to send along with it, and I'm not going to be having to take the time to collect all that information to send it. I'm not going to have, yeah.
So this is from the ED.
Yeah, like I get a phone call about something. I don't want to have to go online to then have to figure this out. Like I could be in the OR, I could be somewhere where I'm not really, it's not convenient for me to send the referral, and I don't want to have it be on my head to actually have to then contact the CAS clinic to make sure that the appointment is getting sent and being organized.
Okay, so that's fair. I have this alternative solution, which is you maintain this, and let's say you're maintaining the referring provider to enter the order on Power Chart. The only thing is that we'd have to recognize that they would need to enter. can you see this? I'm going to
Yep.
zoom in. That they would need to enter somewhere on the referral order that it was discussed with you.
Correct.
So that is an alternative option that we can do. That's totally fine. I just want to present one more thing, which is the triaging process. And if that isn't appropriate for the clinic, then that's fine. The way either or the provider entering from the ED or you as the ortho entering, it's still built the exact same way. It's just your workflow. It'll make sense when you see it. Okay.
The only other thing too is this is only talking about referrals. I'm sorry if I'm talking, you already know this, but we get patients that get sent to our CAS clinic that we've already seen, such as post-operative patients or patients that are up on the ward that have to be booked into the clinic.
Yeah, you could put in a follow-up to CAS clinic order when you see the patient or after you're
Usually
done
it's not me
your
doing it, but I guess that's
Okay.
what I'm having to do now. Like usually, okay. So that's would be part of the post-operative orders. I'd have to fill something out as far as a referral to my own CAS clinic.
Yeah. So, well, let's say you have someone coming from the ED and you have done surgery on them. They've never been seen in the CAS clinic before. You could put in the follow-up order for that patient, which is, it'll be like a like a quick, on the quick order sheets. Yeah.
Okay.
I like your questions. You're jumping ahead. You're thinking. This is good stuff.
How are the other surgeons in the other places doing this? Are they actually putting in the referral orders like you're suggesting, or are they doing it differently? Like going back to this scenario that you were just talking about.
Theirs is a bit different because from what I understand, they're using a different system, like I forgot what it's called. It starts with a P. If someone could remind me of the name, it's Proximus or something. Yeah, Plexia. So I think it's more so that process where they have this all accumulated and they hand it over. But I'm not sure if that's something that you're already using in this clinic.
I don't know if they. No, I'm not sure that they do it that way in the. Well, I don't know. I guess I'm not in their hospitals. But previously, when I was a resident, I don't remember them. Plexia would be their personal electronic medical record system, like we use Input Health. And so we put all these things in our own records, and it is kind of a dual sort of thing. Like I'm sitting here looking at my Input Health records, and my assistant has already input all the patients that I'm seeing in the CAS clinic, right? Because that's how I do my billing, and there's a bunch of things that I need to do that I can do more easily through my own internal medical record system. But I don't. That's not what's scheduled as a CAS clinic, because the CAS clinic's associated with the hospital, and I would assume that's the same at Vancouver General Hospital, these other places. But I could be wrong. If you're saying they do it differently, I'm just not sure how they do it differently. But
there's
anyhow.
So many different ways to do it. I mean, we could do it this way. We could do it a triage method as well, and I can show you that workflow in the next slide. If you have any other questions before I do that.
No.
Okay. So if we're maintaining the same workflow, you're having a phone-to-phone conversation, and then the referring provider is entering it in Power Chart, you still need to review the chart. So the CAS clerk needs to set this encounter for ready for triage. Okay. So when they put it ready for triage, they need to wait for you to review your referral management list and enter a accept referral order, and then the clerk can book it.
Again, I think that's going to be a challenge because not many
Yeah.
people sit and wait and go through all their, like these patients need to get seen. So we don't really, there's no triaging. It gets referred to the CAS clinic, it gets put in. I prefer your idea of they need to have something written that says discussed with this surgeon. And if it's not discussed with, then I guess those ones can be highlighted by the clerk, and the clerk can say, hey, I got this sent to me. Is this one you want to see in the CAS clinic or not?
Yeah, so let's do that. So it's going to be not the ortho provider, it's going to be the referring provider entering into Power Chart, but they need to add, this is going to be an education piece, add.
And they already should be doing that, right? We already have a form in the system that you have to check a box off that you've talked to. And really, there's, in my mind, there shouldn't be a situation where they haven't talked to us.
Okay, so if we're like imagining this is happening, so you have this discussion with the referring provider. At that point, it would be helpful if you just let them know, oh, by the way, you're going to be the one to be putting it in, and please add discussed with myself in the comments section. That's fine. Okay. All right. So we can go with this. This workflow is a no-go.
I think the key too is just explaining, I don't know when you do your teaching sessions with the emergency physicians, but you know, letting them know that this is how the CAS clinic is going to work. You need to actually contact the orthopedic surgeon before you can just send someone to the CAS clinic. It's not going to get input unless there's been a confirmation that the patient can be seen there.
I agree. I mean, that's currently a problem that is happening even without Cerner. So it'll be, there's going to be some pain getting this system done. So that being said, the clerk, if this clerk does get a referral and it doesn't say as discussed with Dr. Orthopedic Surgeon, what do you want her to do? Do you want her to talk to you and then accept it? Or do you want you to be the one to enter the order?
I'm not sure what RE does right now, and probably every surgeon thinks differently on how they want it to do it. Personally, I would love her to tell me, hey, I've got these. She hasn't, I don't think, necessarily been doing that, because I like today, there was a couple patients that were referred to me that no one ever talked to me about. But I think the thing is, I do my CAS clinic totally different than other people. I look up the CAS clinic beforehand. I theoretically could do a triage, but I know that not everybody does it that way. The majority just show up in the morning and go, okay, who have I got on the list? And then they start working their way through it. So that's why it really kind of depends on each person. And I think we'll just have to individualize that part and just communicate with Ari, whoever the booking clerk is at the time.
Okay, so it sounds like, just to make things simple for the ortho providers, that if the clerk gets a referral order into the CAS clinic that is not clear whether or not they had a discussion with you, they talk to you in whichever form is most convenient for whichever provider, email, in person. Ari's been there for a long time. I'm confident that she knows the best way to communicate with whichever provider.
Agreed. I mean, it's good to have a process, because Ari might say, this is it, I can't stand this anymore, I'm getting out of here. And then we're going to have a plan set up for when she's gone, because, you know, she, I think, makes it a lot easier for us. But yeah, I agree.
Okay, let's do that then. And then we'll make that part of the learning for the ED docs and the ortho providers, to make sure that the referring provider is entering what they need to do to make Ari's life easier.
Perfect.
Okay, perfect. Okay, so moving on externally. So external workflow, it's likely going to be a triaging process, because I assume that you don't want to have whatever referral coming in from UPCC or a GP office just automatically being booked in.
So UPCC physicians have to call us and talk to us, just like the emergency department. So it's very much like the emergency department type referral, in that they need to speak with us and we need to confirm that it's going into a CAS clinic before they can send it. I don't think, again, I don't love the triage process, because the triage process, you know, when these patients are getting referred to CAS clinic, the point is that it needs to get seen quickly.
Yeah,
so
it's just,
you're not,
it being off Cerner, we need to somehow get those faxes.
Can they fax something and have it say discussed with, just like we're saying the emergency doctors have to?
Ishti, are you on the line by chance? Or Katie?
Yeah, I'm just trying to, sorry, Katie here. Just trying to think about the workflow there, because faxing is another additional workflow. We're trying to kind of step away from faxing like a paper form, but I don't know if maybe a reference text, and then the provider would have to, like the referring provider would then have to create a dynamic documentation using an auto text maybe. Just thinking like that's what they have to do from, like for example, in the eye care center, the emergency outpatient opto clinic, they only accept referrals from emergency. So, but there is a reference text that pops up when they're placing that order to let the referring provider know that these are the steps that have to be taken in order for them to actually place the referral order into the clinic. So they have to go and write that note But I'm just trying to think of how the clerk would then be able to see, like maybe they have to check to see if there was that note.
So top of my head, this is what I'm thinking. Let me know if this is possible. So the referring provider, they're setting that referral form. They're just gonna, is it possible for them to just write, as discussed with so-and-so Dr. Douglas, fax it into the CAS clerk, and then the CAS clerk indexes it into the patient's chart. And then they can just go ahead, and book it.
Yeah, no, that's a really good point. They could just make a note on the referral, and then the clerk's going to see that in the work queue monitor.
Okay, so then that being said, if they don't write, as discussed with Dr. Douglas, what do they do then?
I would want Ari to contact the surgeon and say, hey, I got this referral. Is this something you want to see?
Okay, so any, from the scheduling perspective, is there any concerns that you see with this?
One thing about, I don't want to make it too complicated for the family doctors. You know, what happens is we occasionally get referrals to our office that are CAS clinic, deemed to be CAS clinic appropriate.
Mm-hmm.
And so we have to figure out what we do with those referrals as well. Ideally, I would like it to be very, what I worry about is if I talk to somebody on the phone and say, send it to the CAS clinic, and they have to send some complicated digital thing and they don't know what they're doing. It's an older family physician. And then he just gets fed up and just sends the referral to my office. And then my office is having to deal with it. So ideally having a fairly straightforward system that we can maybe just communicate to the family doctors, send this through this system. But then also, I think we're going to have a way, I guess that's the one part that's not on there. Like, what do we do with the referrals that we get to our office that we think should actually be seen in the CAS clinic?
I think you can use your usual mode of communication, which is the MOA talking to Ari.
Okay, just booking it. We don't have to do anything crazy there.
Yeah,
For the
because I
ones
mean,
that we're aware of.
yeah, they've talked to you directly, and it's from the office to you guys, so I don't think that should be an issue.
That's not going to be the problem. It'll be more the family physician that I talk to on the phone, and I say, send a referral into the CAS clinic. So they bypass my office. They just send it to the CAS clinic, just making sure that they write that they've spoken to me.
Okay. Okay, so just for Tyler and for Simone, any concerns that you see if we just remove the triaging process and just stick with like all referrals coming in, and it's, I guess, essentially the clerk's responsibility to see whether or not it says on the external referral as discussed with Dr. So-and-so.
So we would not be using that accept referral?
It sounds like we would just be removing that
Okay.
referral.
Yep, so no concerns from my perspective.
Okay.
No, that shouldn't be an issue.
Okay, excellent. So admittedly, even easier on build, or sorry, on a Cerna perspective as well, if we eliminate this anyways. Anything else, any questions or anything you wanted to add, Dr. Douglas?
Just, I mean, the usual things that I know Ari deals with already is just making sure that the referral doctor puts the right patient or right surgeon's name, because there's all of us. And so sometimes there can be confusion there based on who it's actually supposed to be seen by. Yeah. But I suppose if they've said directly discussed with a surgeon, then she would know that that's the person that it's supposed to go to.
Mm-hmm. So yeah, I just want to highlight that what we had presented was it was in consideration that the referring provider would forget those things, but moving forward, like we want to make it as simple as possible for the CAS Connect, but we are relying on the referring provider to be the one to put the as discussed with.
The other thing is on our forms, I'm not sure if this is mentioned anywhere, is that I'll have time frames. Like sometimes I want to see something right away, but there's some things I'm like, well, I don't want to see this for 5 weeks. So I have to make sure that there's something on the referral form to let Ari know or the clerk know when it is I want that patient to be booked.
And so that would be in your scheduling priority drop-down menu. You'll have different options on there. Or you can make it even more specified, which is the special instructions section. That's
what the person is who's filling out the referral will fill out.
Oh, for you, sorry, if there's a follow-up for you, if you're putting in the follow-up for yourself.
No. So what I'm saying is I talked to the emergency physician. He's got this ankle sprain that doesn't have a family doctor to follow up with. So I'll say, okay, well, I want to see that in 5 weeks. Send a CAS clinic referral, but I tell them that I want to see it in 5 weeks. I don't want to see it in my next CAS clinic because most things I just
Oh, I
want to
see.
see. So is there a way for them to be able to communicate to Ari that I want to see it in 5 weeks?
It's gonna be through this, what you see on the screen. They're gonna have to be the ones to write it in.
Okay. But they're having to fill that out anyways when they make a referral.
Yeah, so when you talk to them, you give them instructions of exactly what you want that would be communicated to RA.
Okay. Okay. So that's that same special instructions part where you
Yeah.
said that. Okay. Good. Thanks.
Yeah, no problem. Okay, so let me just, I mean, you can already see in the screen, we've discussed this in the past few minutes. So the only other required fields is going to be your location, which is going to be RHS CAS clinic, and then you're going to put, or the provider is going to be, sorry, the referring provider is going to be putting the referral, like the reason for the referral. So when they're doing that and that's entered, it's going to show up in the orders profile as this schedule here, and that's just shows them that it's been entered. Okay. So we can skip this external referral portion because it sounds like we're not going to be doing triage anymore. So the next thing that I wanted to discuss is scheduling order naming convention. So there was a bit of back and forth discussion in the design session with the non-physicians. And it was mostly because they wanted to capture and differentiate the different patients coming into the clinic. So that being the follow-up clinic orders. So the two different patients that are being seen would be your regular CAS clinic who's being referred in. You're going to see them as a consult. They're going to go in the elective slate, have surgery, and they're going to be seen again eventually in the CAS clinic. So the name of convention that was determined by the non-providers was a CAS follow-up, as opposed to the other workflow of patients that you might see in which they're seen in the ED. They get put on the ED slate and they have their surgery, but they only get seen by the CAS clinic for the first time after their surgery. And so that naming convention was post-op follow-up. Is this something that is clear to you, or is that acceptable to you? Okay.
I'm just trying to figure this out. So sorry, patient for the problem is a little bit, it's confusing me. Patient referred to CAS clinic. Sorry, surgeon plan elected. So what are these for? This is for patients that are, these are the types of consults that we're getting. Follow-up in the CAS clinic, post-op follow-up versus CAS follow-up. So CAS follow-up is what? CAS follow-up is?
You're being seen twice, before surgery and after surgery. I believe that this is for statistics collection, is why they're wanting to differentiate these.
What's confusing to me is that we don't see elective patients. We don't put patients in elective slates, theoretically, from the CAS clinic. So that number one just doesn't make any sense to me. If I see a patient that's referred, like and it's not our knee arthritis is the other thing that's confusing me, because that's like an elective problem. That's like a non-urgent, it's not a fracture. We usually see things like a wrist fracture. So if I see a CAS clinic, there's been something that I got called about, a wrist fracture. It gets sent to my CAS clinic. I see it. I think it needs surgery. Then they get booked for the emergency slate. They then have their operation done by whoever one of our groups that does it on the emergency slate. And then they're going to be followed up back in the CAS clinic afterwards. And that would be you could call that a post-op follow-up.
So the details of it, it was not correct initially.
That's okay.
So I just put it in. So it's still technically being seen twice in number one. And then the second one is just being seen afterwards.
But that is for the emergency slate. That's a patient that's surgical, right? So put on the piece seen in emergency department, put on emergency slate. So sometimes they're not seen in emergency department though, right? Sometimes they are seen. Like, why are they considered something different? They're both the same. I don't understand why statistically that matters. Like what we see post-op, the post-op follow-ups that we get, the other post-op follow-up is a patient that I saw in my office that's had surgery. And then the very first post-op visit is done in the CAS clinic because I have wound care stuff here. I have the physio here. There's reasons for why even elective patients will get seen initially in the fall in the CAS clinic. So that is what I would consider a post-op follow-up patient, right? So that patient, their first visit in the CAS clinic will be after surgery, right? But they are a post-op elective follow-up. But there's really no difference between that and a post-op trauma patient that got booked through the CAS clinic or got booked through emergency department that had their surgery and then comes back. They're a post-op follow-up.
Does that look better? Am I capturing that? So the second one is the first visit is after surgery. The first one is they're being seen twice. So one before and one after.
I don't understand what's number one. You're trying to figure out what the appointments types from above. So you've got CAS new, CAS follow-up, post-op follow-up, right?
Yes.
And then what are you trying to differentiate between number one and number two?
See,
what should number one be called?
Yeah, I think we'll probably need to also discuss with Mary and Jonathan what it is that they're wanting to capture. And if it actually really matters to capture that information, or if it's just going to complicate things.
Yeah, I agree. A CAS follow-up in my mind would be someone who's not had surgery that you're just following up and well, I shouldn't say that. I mean, you're going to have multiple post-op. I mean, it depends on how frequently do you want to call it a post-op follow-up, because you're going to see them more than once after surgery as well, right?
Mm-hmm.
The trauma patients, the elective patients, we may only see one time, and then they'll go and for the most part, for the rest of the time, be seen in our office. But the post-op wrist fracture, the emergency patient that got surgery, they will then get seen subsequently until they're discharged from myself. Like, not plan on not seeing them anymore.
Okay.
And we don't differentiate between post-op follow-ups and CAS clinic follow-ups. I know my secretary sometimes, or my office sometimes tries to do that in our input, but at the end of the day, I don't think it doesn't matter that much to me. I'm not sure if there's some statistical reason why other people care, but it's just that it's a follow-up patient versus a new consult.
Sorry, I'm just thinking here.
But you're right in that I don't know why the reason is for why they want to capture that stuff. So maybe there's some reason for it that I'm not aware of. And so if that's the case, then we'd have to kind of figure out what we want to call them. But it gets a bit murky as far as, as I said, like the first post-op visit is probably the most important and kind of is a bit of a different patient than once you're 3 months out. Yeah, you're post-op, but you're very similar to what the regular follow-up patient would be at that point. You're not requiring dressings or anything like that. Wounds are usually healed, so but again, I don't know if that's what they're looking for. Like, why does it matter?
Okay. Is there a difference, Dr. Douglas, from informatics as well? Is there a difference in the amount of time that you would spend on each patient?
Possibly. That would be the only thing, right? A post-op patient would have wound kind of things that have to happen. Our physio has to remove the stitches, so there might be some things like that you would have to be aware of, that it might take a bit longer to manage that patient. So that would be possibly one of the reasons. But
right.
It's such a heterogeneous group of patients that it could be two totally different things. You could have a knee scope, which is like nothing, right? There's not even stitches. And then you could have some massive femur fracture that's got like 50 stitches down the leg. So you wouldn't be able to capture that in that category. And I wouldn't want to be that detailed in the description of each one, because that would just bog everybody down.
Okay, so it sounds like it's just from your perspective, there is stats wise, it's not something that's important to the providers. But I'm also wondering, does that have anything to do with your OR hours? Like, would they need this information to justify more OR time for you?
I don't think they're basing our CAS clinics on that. Like, base our OR time on, I mean, I don't think it matters.
Okay.
I don't know if it would matter. The only differentiation might be between how many elective patients we're seeing in our CAS clinic versus how many of these on-call emergency patients. But I've always argued that that doesn't really matter in the grand scheme of things. It is the number of patients that we're seeing, regardless of where they're coming from, that really should dictate, you know, how much help we need, how much space we need, all these sorts of things. And I don't think it affects our OR time. Our OR time is affected based on, you know, how many patients we have on our slates at this stage. So, yeah, not that I can think of.
Okay.
Is this something that's, again, this is a question I would have for all the other CAS clinics and all the other places that this is done. Like some people should, maybe some CAS clinics see more of their elective patients in CAS clinic.
Okay.
But I don't know what other people do. But it's nice to know what other people do so you're not just reinventing the wheel. I'll just keep saying that.
At VGH and at St. Paul's, they do differentiate between a post-op follow-up and CAS follow-up only because of the time, but they also see a slightly different demographic of patients than you do. So maybe it matters more to them and their statistics rather than for Richmond.
You know what? And then you know what the problem with St. Paul's and Vancouver specifically is? The Vancouver group, the trauma group, all they see is emergency things. They'll do very few elective, and I think they probably just fit the elective in with all of their trauma. So they just see everything in their trauma rooms versus their CAS clinics versus our CAS clinics are very, you know, other than the post-op, I would say, at least for my practice, and I think the majority of us, other than the post-op the first post-op visit, everyone else that's seen in my CAS clinic is basically the trauma patients, the emergency patients. At St. Paul's, don't they have their CAS clinic at their office? So they probably just mix everything in, and I'd imagine that they don't have very much differentiation between a CAS clinic and what a normal office would be.
You're right. I mean, the main difference with that for them is that when their medical office assistant books their clinic appointments, they send us late to the CAS clinic for them to book it into.
Right.
And they see them like normal.
Right.
And sometimes it gets really crazy, but
I'm sure it can get mixed up. So that's where here I think we do have sort of distinct differences between our CAS clinic and not. Now, Lions Gate Hospital might be the one that would be closer to what we do, but I'm not sure. I actually know some people in Kamloops who apparently they just run regular clinics in their CAS. I know it's got nothing to do with this, but it just shows you that there's very different ways of being able to run a CAS clinic. And so that's what does make it a bit challenging. But here, basically, you know, how we do it is we're primarily seeing our trauma patients, whether they're non-operative or operative, the emergency patients is the other name for it, I guess, and then also just post-op elective, kind of the first visit.
Okay, so I think it sounds like we'll just have to discuss a little bit further what it is that they're wanting to capture and the rationale for it. And we'll have a better idea. But it sounds like we are just leaning towards a generic follow-up appointment type for now. Okay, so Simone, did you actually have anything to add in that respect, or I can just move on to the day visit?
No, you can continue on. Thank you.
Okay.
I'm making notes on my side as far as the changes in the appointment types.
Excellent. So, Dr. Douglas, do we have Waitwell yet at Richmond? Because I know that you guys got an iPad or something like that. If you're speaking it, you might be on mute.
Oh, sorry about that. I got distracted. What was your question?
Do you have Waitwell already live at Richmond?
If we do, I don't use it.
Okay. Okay, I'm guessing that you don't have any background on the functionality in the clinic for now.
For that part, probably not, no.
Okay, all right. So
I think we did try Waitwell. Waitwell, they tried it here and it was a gong show because patients had to sign in and they weren't signing in and it was delaying patients even longer from being seen. So I think they ended up stopping it.
You know, that's good to hear because I was looking into it and it sounded like a lot more work than would be necessary for a high volume clinic. Okay, so that being said, we don't have wait while, so that's fine. So the day of visit is, so for the day of visit, the patient is going to be coming into the clinic. They're going to be registered in main admitting, just like they normally are. They're met by the clinic aide. The patient is going to be brought to either x-ray or inside the clinic or in the waiting room, depending on whether or not they have the orders for x-ray already in their charts. And they'll be seen by RA if necessary. This is where you come in. You would be, now that you don't have wait while, you could be monitoring your ambulatory organizer, which I showed you in the last session, and I can show you today. And it'll tell you whether or not the patient has been checked in. And let me just pop into that right now so I can show you. Oh, actually, let me see. So before I move forward, I just wanted to let you know that after you see the patient, you would be just doing your documentation assessment, adding orders as necessary. If the patient is going to be seen by physio, they'll be seen right after that. And then once you're done, if you want this patient to be seen again, you would just write your follow-up order, and that'll show up on RE's future request list. If in the case that you see a patient and you want them to be on either the emerge slate or you want them to be seen in surgery, you'll be following their workflow process. So contacting the booking clerk, if this patient's going to go on a, what do you call it, on a regular slate. If it is an emergency for some reason they came in and they're more injured than initially anticipated, you would be talking to the OR desk as you normally would to have that patient booked in. So, or like you would normally do your consent by paper, have the patient fill out their questionnaires by paper as well. And this can be left with the at the OR desk or like you normally would when you walk it over or in the PAC, be sent to the PAC clinic. Does that make sense so far?
No, not really. I'm worried that it's going to be complicated, but yeah,
Okay.
that's what I'm worried, because it sounds, I don't know. The problem right now is everything is right. So much done via paper. It's kind of very efficient in that regard. This sounds like it's going to be less efficient.
Okay, so let me just show you on what it's going to look like when a patient arrives. So it's logged me out, so I'm gonna have to log in again. So I see that Ari and who else has joined in from Sneeze? So I'm just finishing up with Dr. Douglas here, and then we'll start again with the non-providers here.
And Dr. Douglas, you
Great,
wouldn't
thanks.
have to log in every time, like we're doing for this demo.
Yeah,
I should be worried.
so when you're logging in for the day, you only have to do it once. And so, you know, you've opted into your clinic, you're looking at your current day. These are the patients that's going to be in for the day, the time. It's you, the patient, you can, you know, hover over.
Right. And these are patients that are already in the CAS clinic, or is there a schedule that I can look at before?
You can change your day. So let's say on the 19th, or sorry, I guess, yeah, you can look at the patients on the 19th and you can check their charts. You can enter the orders if you want for your x-ray as you normally would.
Yeah, this is my personal thing. That's what I was just trying to figure out when you're kind of describing that flow, is that I like to order the x-rays before I know that they're even here yet, right? I'll plan the night before, write all the x-ray recs out so that Takami and Ari have them, so that the patient doesn't even have to come in to see me. They just go directly to x-ray first. But I'm the only one I think that does that. So my workflow is a little bit different than other people. I just don't want that to be disrupted, but I also don't want to disrupt everybody else's workflow that could be different than mine.
No, it's not going to disrupt. I mean, you can even look up, so it's Friday today, you want to look up Monday, you can do so. It's not built into, oh, it is built. So you could look into Miranda here, click into their chart. You review their, you go into your provider view, look at the basic information. You want to see their diagnostics. If they don't have one, then you can make that order by adding it here. Sorry, it's actually probably easier to show you the quick orders. So quick order sheet here. Then you can do your X-ray. X-rays are all there. If you have anything else that you want the patient to,
the patient's already had
done.
an X-ray. Can you just repeat the X-ray that was done before? Is it even easier than that, or
you could do it through the outpatient quick orders
you
in
can
the
have
same way.
the previous X-rays that they've had, so you're not having to search through that list of 20 X-rays?
If you want to just quickly search it, you could do new order entry, and then you just enter the X-ray that you're wanting the patient to see just by doing a more broader search.
All right, you still having to write it down. It's not like you just click and see, okay, this is the old X-ray that they had done, just do it again.
Well, if you're viewing, let's just see documentation wise. So it's hard to actually show you without it actually built in. So sorry, provider view. It's a bit laggy on build. So diagnostics, you would view it here. You on the same page here, you could add your orders. It's just a difference of one click. Either here, review it, and you add the order there. It's not 5 clicks, it's just the one.
Okay.
Okay. So back to what I was talking about. So
Yeah.
you could review the day before if you want to. If that's not your workflow, your colleague doesn't do that, then that's fine. They can, on the day of, so it's October 20th, they'd go in, click into the patient, see what they need to see, and request an order for X-ray there.
Okay.
Yeah, so there's going to be an X-ray tech that's going to be on site, and from what I understand, they're just kind of in the clinic. They can just take the patient over as necessary if the patient's already sitting in the clinic. Or they could have the C-arm done at the bedside as well. It's really up to them.
Everyone does it differently. Unfortunately, I do not have the CAS clinic in my CAS clinic. That's a CAS tech. The CAS tech stays in radiology, and it's it's our Cora, who takes the patients to the X-ray and then brings them back.
Okay, yeah, so that's fine because that doesn't really matter for Cerner perspective. Okay. What else? So I'm gonna go back to the demo here. Yeah, so documentation wise, I did reach out to the other doctors and 2 other clinics, and they haven't returned my email. So I just took it upon myself to go to one of the CAS clinics and see what the most common documentation that they use. And these are the most common ones. So you have one that's specific for WorkSafe BC. For the most commonly used one for follow-up, they use an outpatient clinic note. And these are the categories that are on there. You have a SOAP note. They typically use for CAS new, but these are just your standard templates. I find that most do utilize that. I've gone through quite a bit of charts, but you can have one built for yourself. So an auto text in which you would put in the name of your auto text that was built, and then you can just use your own. But you could take a look at any of these notes and see which one works best for you, and then tweak it from there.
Yeah, can you actually so you can change it just for your own personal, the way you like it?
Yeah, you can copy and paste what is currently on there when we're building a new auto text for you, or if you're building one for yourself, and then you can add, subtract whatever's on there. So let's go into a patient's chart and we're gonna go to a quick order. So actually, let's do the documentation add. Going to be based on position. And then let's see, orthopedic surgery consult. So let's get that one. Is there a free text? Let's just do a free text one. We'll just do free text here, just for ease. Maybe I'll just do a quick order one piece note. This one's a bit different build. Okay. I can show you just after the session, and then you can I'll have a copy and paste the different documentation styles, and then whichever one that you find is most relatable for you, then you
So
can
what
just
you're just saying
decide.
that it opens up, instead of free text, it just has text that's kind of already written, and then you can just fill in the blanks where you want to have blanks filled. Is that what you're meaning?
Well, these are the templates. So what we could do is do an auto text. So you would make your, sorry, I'm just now clicking around here. So you would make your own documentation. So you would have to actually make your own for the first time auto text. And then once that's created, you can just put in the name of that auto text into each chart that you do. So you can have one just for consult. You can make one just for post-op. It's really
A
up to
generic
you.
one that can be used for every patient.
Or you can do one for generic for every patient.
Well, I just don't want to have to plug that in every single time the first time. You mean the very first time when I'm just
The very
creating,
first time you have to create the template.
but not for every patient
No.
the very first time. Just
So
the very
then
first time.
you would
Sorry.
put the name of the text in the text note type, and then it'll pop up. And then you can just continue with your charting.
Okay, and then I can use that when I open up a new patient at some point. I've already put that stuff in somewhere and I can reuse it.
Yep.
Okay.
So I built one for physiotherapy. So their note type is CCPT, and it'll be the same every single time. I built one for the fracture liaison.
Okay.
It's going to be the same. They just put in the name of their auto text name, and then they continue for every single one of their patients.
Okay.
Okay.
Is that what you were leading to? That was what you're kind of talking about, where this stuff right here, consult note? Is that what you're just
Yes.
creating kind of this is what it could be, something that you could create for us so we're not having to create it the first time?
Well, you have to create it for the first time, but once you save it, you can name it whatever you want to name it. You can, and then use it for whatever future patient.
Okay, sorry. So this is just you giving us an example of what I could do myself.
Yeah, so I'm saying like these are the common ones that are on a template. I find that a lot of providers are just using the basic template. You have the freedom to make your own. Perhaps you see the consult note, you don't want all these allergies, you don't want to
Right.
have the physical exam. You can just copy what they have there, the way that they set it up, and then name it whatever you want to name it. And then for any future patient that you want to document, then you can do so.
Okay.
Okay.
And sorry,
Dr.
it's
Douglas,
Dolores. Oh, sorry, go ahead. I just had a quick comment.
Yeah, we could also help you set this up if you have a note already in mind, and we could put it into the auto text, and at go live, all you would have to do would be copy it from my access to your access. And then once you're typing the note, you just type in your token, whatever we decide to call it,
Right.
RHS gas
One
clinic,
thing-
and then it populates.
That's great. I mean, there's things about the CAS clinic. It's because it's so you're seeing the same patients over and over again. There's parts that I would love it to just be able to just have something that's permanently in there every time I set up a follow-up note, like this patient with a proximal humerus fracture. It should just say, 60, reason for referral, left proximal humerus fracture. And then what I love to have is something where you can input the date of injury or the date of surgery. And then the absolute dream, although I'm not sure this is possible because I can't get my external input health EMR to do this, but I'd love to have a way of calculating the weeks from that point of that date to now, because that's usually the most important thing when it comes to orthopedics in my mind, is like, how long has it been since their injury? And that's usually information I want to have in the chart, because then that indicates to me what I should be looking for, how far along they should be, all these sorts of things. But I'm always having to calculate it myself beforehand, the night before, and I find it just irritating because it takes forever. And it would just be great if there was a way of doing it, but I'm not sure that there is.
So what you're describing is like a token. So it could pull some information from your chart. I don't know about calculation. Does anybody know if there's a token that calculates the day of visit or something like that? How many days?
Hey, this is Fraser from the PET team. I think that's theoretically possible. It would need to be a custom built one, so it would be new request that would have to be approved. But I think theoretically it's possible.
I can ask the other surgeons if they would find that helpful or not. I personally would find it very helpful, but I don't want to make a huge work project if it's only me, but I can get back to you.
Yeah, I'll take a quick look and see if there's something comparable.
That'd be great. Thank you.
Okay. So
yeah, go ahead.
So I'll just show you. I'm just going to pick a random note here. So this is the nursing one that was built out for Maggie. So we had named it FF. So this is a custom one that was built for her. So all she needs to do is put comma, FF. That's just a random name that I've given it.
Yeah.
And then she has drop down menus. She could put tokens to put information from the chart through to the chart to your end note here. But this is built specifically for her. And this is something that you can do for yourself if the template that is currently on Cerner is not usable for you.
Got it.
Okay, excellent. Okay, so let me take a look at where we're at. All right, so we've shown you ambulatory organizer already, and so this is more so, we're just too far here. We've already shown you this, we've discussed this, documentation, message center. Okay, so message center. There was a point in our last discussion that there might be a referral that you're making to another ortho provider. Not very common, but if you do, you could always send it through message center. So I'd have to log back. I'll just show you from here because this is essentially the same thing. So if you wanted to send a message to your colleague about a patient, like, hey, I saw this person at the CAS clinic, they're complex ankle. Can you take a look at this patient? I did the consult, here's your information. In the context of the patient's chart, you could actually communicate this to your colleague. So the patient's name's on there, you can CC the doctor that you have. So maybe it's Dr. Calvert, and you can put any other details that you want and you can send it forward to that patient. Okay.
And I'd want to do that if I'm sending a referral. So if I'm putting that patient in his CAS clinic?
Yeah, so there's two things that you'd mentioned, that if surgery is more complicated than initially anticipated, and you're going to hand it over to your colleague.
Somebody else.
Yeah, or if you're on a Friday and your colleague is in surgery, and you're going to book this patient in for a Friday, they were supposed to be seen by you, but for some reason you're wanting this patient to be seen by your colleague in surgery, then that would be how you communicate that most efficiently.
Okay. So then when they opened up the chart of that patient, they're like, why is this person in my CAS clinic? They would have the letter from me.
Exactly.
Yeah.
Yeah. So that's just like an efficient way for them to know what context, like this patient in this patient's chart.
Got it.
So that being said, message center, we do need to have team leads. And since you're the SME, we've put you as the team lead for that. And this is the name of the other providers that are in the clinic. Doesn't mean that you have to be the lead forever. If for some reason you wanted to pass the torch on to another provider, that can be done. But otherwise, there's not really much of a responsibility on your end. It's just it has to have someone's name as the lead.
Sure.
Okay, and then for you could also message the other pool, so clinical. That would be Takami and Maggie if that's ever needed, or if you wanted to be sending it to Ari or Sylvia.
Got it.
Okay, so what that looks like is here's the pool. You would just be managing who you want, which pool that you want to be reviewing. And if you want to create a message and send it to one of those pools to all the other providers. So it's like, hey, you want to send a message to all the docs in the CAS clinic while you're gone about, I don't know, whatever you wanted them to know about. You can just find them on this pool, RHS.
Is that attached to one patient, or is that attached to just not attached to anybody?
It's not. Let's say like you're going to be gone for the next like couple weeks, and you want, or if you want some sort of message to be sent to all the other providers, you can add this pool in and send a message to all of them at once.
So is this just like a, well, I'm just trying to think of like a phone app, like WhatsApp or something like that, where you can just communicate back and forth between each other?
If you want to, with all the, you want something to satellite to all the providers, if you want to just send it to one provider, you can do that as well.
Well, I think it would be helpful because for us, one of the big things we have to do is hand over of patients on call. And this has always been an issue right now, is that we are doing it in via ways, we want to try and do it as securely as possible. And I would imagine doing it through Cerner would be the most secure way of handing over patients. So is this being used by other hospitals as a way of communicating handover of patients?
Yeah, that's one way. Doing a direct message, but you could also make proxies. Sorry, so if you have a list of your own that you want to have managed for handing over to your patient, to your partner, you can have that list created and share that with your colleague.
Or
they can have
more than one
colleagues or more than one. Yeah. So then they'll all have access to the patient list that you have and whatever tasks that you have on there.
Perfect.
So that's a function of Message Center.
Okay.
Okay, so let's go back to the power chart. Okay, so the lead for it's going to be Takami for the clinical, and the admin is going to be Ari. Is that okay with you?
Yeah.
Excellent. Okay, which takes us to the non-providers. So Dr. Douglas, a lot of discussion, learned a lot from what would work best in the CAS clinic. Do you have any other questions or concerns coming forward? I know it seems like a lot and that it seems complicated, but once you get into the system, you'll find that there's a lot of different functionality and customizability that you or your colleagues can use on Cerner to make it user-friendly for yourself.
Sounds good. Thank you.
Yeah, no problem. Any questions for Dr. Douglas from the rest of the team?
It's Claire again, Dr. Douglas. Just wondering if you wanted to send us a few examples of your notes and then we could get started on it for you.
Yeah, like a CAS clinic note. Is that what you want?
Yeah. So we could show it to you a little bit more personalized than what our general, this is what you're going to see we did today.
Yeah, I mean, I actually have a little photocopy of a history and progress note that I wrote kind of the things that I want and I use every day. So I could give that to you, but it's only me that uses it, right? I don't think the other guys do it this way. I know they don't do it this way. So, but yeah, I can give you.
That's all right. I mean, if we could get it set up for you, they may want to copy you.
Correct.
But it'll be up to them and it'll just be a matter of, like I said, copying the auto text.
Yeah.
Thank you.
Yeah. Okay, excellent. So let's see. Anything Simone, you want to clarify with Dr. Douglas before we move on?
How do you want me to send that? Actually, is the question I would have. Like
You
email.
could send it.
Yes,
Sorry.
email to the group is okay.
Okay.
Okay. Excellent. So we can move on to the non-provider. Dr. Douglas, I know you've got some pickup time that you need
Thank
to
you.
attend
Yes.
to.
I appreciate it.
Okay, thank you so much for
Yep.
your feedback.
Thanks, guys. Bye. Yeah, you're welcome.
Bye-bye. All right, so who do we have on the line right now? So we have Maggie. Do we have Takami on the line yet?
Hi, he's actually sitting with me.
Awesome.
My
So
name's
we
Ari.
have all three people here. Excellent. And do we have Jonathan Chung? Perfect. So we have everyone for today's session. So I'm just gonna backtrack because you guys weren't at the very beginning. So this meeting is being recorded and it's so that we can go back and look through our build for build purposes. So today's agenda is essentially we're going to go through an end-to-end workflow, what it's going to look like for you in the Cerner perspective. And we're going to have some questions related to labeling and registration for you, as well as reviewing a day end-to-end for the day workflow review as well. Okay, so all right, so this slide has changed quite a bit from our discussion with Dr. Douglas. So just as a review, the current workflow is that the referring provider and the ortho provider are having their discussion, and it's determined with this phone call that the if the patient is to be seen in the CAS clinic, would be the referring provider faxing that sheet to the CAS clinic. So you, Ari, as the clerk, would be receiving it through a fax, and then you would be confirming with the patient and booking that patient in for that surgery that appointment, and then that's done deal. So the initial concern was that the ED providers are sometimes sending the referral directly to the CAS clinic without discussion with the ortho provider. So let me just note some changes here based on the discussion. So this is going to be provider. Okay, so for the future state recommendation and discussion with Dr. Douglas is they're going to maintain their current mode of communication with telephone. It's a referring provider who would be entering the order into Power Chart and providing the pertinent data so that you already have what you need in order to book the appointment. So one of the main things that needs to be entered is the discussion with which physician that they had the discussion with, and how the frequency of when they want to see this patient. So if they want to see the patient, the next available patient, or a week from now or 2 weeks from now. So I'm just going to go into Power Chart just to show you what it's going to look like for the referring provider. So what I will do is just X this out. Any questions about that so far? Ari is probably the main person that I'm directing the question to.
Oh no, it's all clear. Thank you.
Okay, excellent. So right now I'm just pretending to be a ED doc here. And I've had a discussion with Dr. Douglas, and Dr. Douglas gave me the go-ahead to book the appointment for the patient into the CAS clinic. So the patient that we're discussing is going to be Danny here. He's from Emerge. I just put a relationship for the patient. And so I've got the go-ahead. I'm going to add, I should do the quick orders. That's fine. Referral to patient cast. I don't see it here. Here, referral to outpatient cast. And so one of the things that I highlighted to Dr. Douglas is that with the workflow that he has decided upon, we are relying on the referring provider to put in those details so that you don't have to have that extra step of talking to Dr. Douglas or the ortho provider to make sure that the discussion took place. So scheduling priority, they need to put in the correct scheduling priority, which is in the, let's say, the next day. And the other required field is the reason for visit. Otherwise, location is going to be the CAS clinic, and it could be either here, as discussed, or it could be in the special instructions here. Doesn't matter which one, as long as it could be seen by you on your end that this conversation took place. So this is going to be kind of a learning pain. It's currently a problem right now in the CAS clinic where you're getting referrals that have not been reviewed by the provider. So I'm just going to get that signed.
Oh, Ari here.
Yep.
So in the last meeting, I was trying to see if you guys can make the requested provider highlighted so they have to fill it out, because the issue with what you guys are proposing is for special instructions, or as discussed, right, with Dr. Blah, I would guarantee like 75% of doctors will miss that. But if you highlight that they have to specify which physician they're referring to, then they can't miss it.
No, I totally agree. I believe Simone had this discussion with the, I think with the building team, the scheduling team, if this is possible. And it seems like it doesn't go along with enterprise. So we can't make this special for this clinic. Simone, do you want to speak more to that?
That is correct. That field, since we use these questions across the enterprise, we're unable to make it mandatory, as it will impact every other clinic that uses it.
So it was a great idea, Ari, but unfortunately we can't make that field required just for this clinic. So when the doctor has, I've emphasized with Dr. Douglas that when he has this conversation with the referring provider, that we are relying on the referring provider to put that in. Because the alternate suggestion that I had for Dr. Douglas was to put it in himself so that you would see the referrals coming from him, and then you can book it right away. But it seems like that's not something that he or the other ortho providers are interested in doing.
Okay, got it.
Okay, so it'll be rough to start likely, but with reminding and education, other clinics can do a similar workflow, and eventually they get it because they want to get their patient in for an appointment. Okay, so back to the demo. We've had the order signed, and then here you'll see that this is the provider's side, but they'll see that there's a scheduling icon here, so it'll show up on your request list. Okay, so I'll go back to the demo. So I did discuss a triaging process, which wasn't my first idea either, but because it would add additional steps. So we were not doing a triaging portion for external either. So similarly to the internal referral process, we're relying on the referring provider to write on that piece of paper that they're faxing to the clinic that they had a discussion with Dr. Douglas. Does that make sense, Ari?
Yep.
Okay, so all of this is going to be deleted. It's not a triaging process. So what's going to happen is the referring provider faxes all the information that's required for booking this patient into the clinic. they've had this discussion with one of the ortho providers, and they write that into the faxed paper. You will receive it on what's called a work queue monitor. And on the work queue monitor, it's going to be a like a virtual fax. So because the provider has indicated that it's been approved, you'll see the faxed sheet on your work queue monitor, and you can go ahead and start indexing this fax sheet into the patient's chart. Okay, so once that is indexed to the patient's chart, you can go ahead and book the appointment for the patient. So what that will look like, it's not fully built in, so I'll just have to show you screenshots. It'd be here. So on the same work queue monitor, you would just be looking for the patient. The details are going to be in the fax sheet that you receive, and then you would add that to the patient's chart. Back on your scheduling appointment book, actually this is not correct. You can actually just book the patient and modify your request list and book the patient in directly and then contact the patient. And this is going to be the same workflow as what you would have for your internal referral process. So there's really only one process. You just need to look up whether or not the internal workflow on Cerner, it specifies that a discussion happened, and if it's through an external, that the faxed work queue monitor says it's accepted by the provider. Does that make sense?
Yep.
Okay, excellent. So I have to jump around because some of these slides have changed based on our discussion with Dr. Douglas. Okay, so scheduling orders. So the last meeting, there was a lot of back and forth regarding the naming convention of the follow-up appointment type name. So the FATCast follow-up and the post-op follow-up. Actually, I should probably look at what I wrote for Dr. Douglas instead. Here. So it was determined with Dr. Douglas that he doesn't really see a value in differentiating the two types. So I let him know that we should probably discuss with the non-providers what it is that is trying to be captured. And so that I'm bringing that question forward to you again today. So why is it that we want to capture the difference between a CAST follow-up and a post-op follow-up?
Oh, you know what? If the doctor doesn't find value in that, then it doesn't matter to us either. It's either new or follow-up then. So CAST new or CAST follow-up will be fine.
Okay.
Yeah.
Okay.
I guess it's more, oh, sorry, you know what? It's because of statistics. That's right. It's because a surgical follow-up also is considered a brand new patient here at the CAST clinic. It's not really a consult with the doctor, but in the clinic's perspective, they've never been seen here, so they are a new patient. So I think it's just stats wise, but I wonder how that would work. I guess that's part of admitting as well. That's how they're gonna know, because if they're gonna see the appointment type upon registration, and if it says follow-up CAST clinic, then they're gonna think it's a follow-up, and then that's how it's gonna be entered into the system. Therefore, our stats aren't gonna be accurate. So I guess a surgical like CAST surgical post-op follow-up. I guess I'm creating the accounts, aren't I? Because I'm booking the appointment, so I'm creating the encounter. So technically I have a pre-account, like I'm the one that determines that, right? Even before they get to admitting. So as long as I know what it is, then I don't know. That's an interesting question.
So stats wise, so you're collecting these stats, but what would be done with that? Is this for
That's the
Some sort of
business side.
funding? Okay.
Personally, I don't know. That's more management.
Okay. And I know that Mary is on vacation at the moment, and she would be the best person to ask about this.
Yeah, yeah, definitely.
John, any thoughts from you? Has Mary talked to you about, the rationale for the stats collection?
Hello, can you hear me?
Yep.
Yeah. So in terms of the stats collection, I think the biggest thing we have to track is volume. In terms of appointment types and whatnot, it boils down to volumes, right? And then also the provider who saw the number of cases per day. And I think those are two really main stats that she would be really interested in.
So it sounds like more so the total volume, not the type.
I think the type would be helpful if we want to talk about operations and efficiencies. What type of stats can you gather in terms of like appointment types?
Anybody on the line can answer that?
I'm sorry, what was that question?
So what type of stats or what type of parameters can you gather from your from the reporting needs aside, like that concerns the appointment types?
I know that there is a pivot report that will capture more or less kind of tallying each type of appointment that you have listed there. I don't know if that's something that would be useful. Other than that, we just have a wide assortment of reports. It's really more dependent on exactly what is it that you're looking for, so we can find if we have anything within scheduling that will fit your need. But I don't know, maybe the pivot report might be helpful to you. But outside of that, off the top of my head, I'm not too sure which other report would provide the most appropriate statistics.
Sounds good. For the pivot report, is that the one that's uniform across all the managers' portfolios?
Yes. Mm-hmm.
Okay. I think in terms of the reporting needs, then we should be okay to stick with the pivot report because I think that's basically what was asked for the other clinics. I think I would wait for Mary to come back next week to really confirm that. But in terms of stats and everything, it's really straightforward. We really just need to capture appointment types, provider, and then any and the volume per period. That's really it.
Okay, so I'll send up a follow-up email with you and Mary in that email, and we'll just hash out what it is exactly wanting to be captured and what can be provided with the pivot report.
Sounds good.
Okay,
Thank you.
perfect. Any questions so far related to any of the workflow that I just presented? Okay, excellent. So I'm going to jump back to the non-provider side. Okay, so that means, yeah, so Simone, I'm gonna hand the mic off to you. Do you want to be sharing your own screen or?
Yes, if you don't mind, thank you.
Okay, I always forget how to do this. How do I stop sharing my screen?
I might just be able to take over.
Okay.
Alrighty, can everyone see my screen?
Yep.
Yeah.
Awesome. Alrighty, let me just get my other notes. And we'll go ahead and get started. So very quickly, I think I have met with everyone on this call, but if I have not met you previously, my name is Simone Edwards. I am the application analyst who's responsible for the design and build of the scheduling portion of the Cerner product. So we will go through a few slides just so you guys can get confirmation, so I can get confirmation on what has been built already, and then we'll hop into the system and do a quick demo. Please, either Kim or Brian, keep me honest on the time. If I need to hurry up or slow down, please just let me know. So to jump right in, we have our resources and appointment types. As the post-op follow-up is still in discussion, I made adjustments earlier on, but we do have the CAS new and the follow-up appointment types. Both of those have a duration of 5 minutes and can be booked every 5 minutes. As you see on the far right, these are all of the physicians listed. So any of these appointment types can be scheduled against any of these resources. It all depends on their actual schedule when they will be dropped on the scheduling appointment book, and we'll go through that in just a moment. Any questions on the appointment type names, the duration, or the resources? Once an order is placed, the order, actually, you know what? I think I want to hop over to this screen first. So before we get to the discussion on orders, let's talk about the books and the resources. So the name of the bookshelf is called RHS CAS Clinic Bookshelf, and the book that holds all of the below listed resources is called RHS CAS Clinic, and the resources are listed here below. In the appointment book, once you open this book, you will see all of the resources listed across the top and their schedules or their slots shown below. This is an example of what you would see. As I previously mentioned, the appointments can be scheduled in one of the 7 provider slots, and it could be booked every 5 minutes, Monday through Friday. On Monday, we have from 8 a.m. to 1 p.m. On Tuesday, we have from 7:30 a.m. to 1 p.m. Wednesday, we have from 8 a.m. to 2 p.m. Thursday is a split day, so we have from 8 a.m. to 12 p.m. and then 12:30 p.m. from 4 p.m. and Friday is 8 a.m. to 1 p.m. Any questions or changes required for this schedule? Okay. So I am going to pop back over here. So as Kim mentioned earlier about placing an order, once the provider places an order within PowerChart, that order will be dropped onto the request queue that can be accessed through the scheduling appointment book. So here's an example of what the request list would look like. As I mentioned, the request list inquiries is populated by the scheduling orders entered by the providers or clinicians within PowerChart. All the information required for scheduling will be entered into the order and displayed on the request list for the clerk to review. These requests can be booked directly from the request list inquiry, and the request can be moved to a wait list or a triage queue if they cannot be scheduled right away. Any questions so far? Okay, and I think it's time for me to hop into the appointment book. So as I mentioned, this is what your scheduling appointment book will look like when you open it. This is the main page that opens up to. During your education sessions, you will be taught how to set your configurations that as soon as you open your appointment book, it will default to automatically to your clinic and today's date. So here we have the RHS CAS Clinic bookshelf and the one book within there. And once you double click it, it will open it up. As today is Friday, we only have Dr. Douglas, a slot for Dr. Douglas. Monday, we have Dr. Calvert. Tuesdays, Dr. Liu. Wednesday, Dr. Kendall. Thursday, Doctors Johnson and Leong. And Friday, as I mentioned, is Dr. Douglas. So from here, we'll go to the request list. And this is where you will be able to pick up that order and schedule it directly. So the order that the provider placed for you will now populate the scheduling request list, and you'll be able to take that off and turn it into an actual appointment. So by default, your request list inquiry will open up to the last request list that you were on. So since I was most recently on the CAS clinic, it opened it up right away. So all I would have to do is click find for it to populate all of the appointments that, or all of the requests or orders that have been placed. So once you come here, you'll locate which order you are looking for, and you will right click, complete your request. And it will open up, there we go. It will open up a version of the OEF that the provider filled out. On this side, we call it the scheduling accept format, as some of this information has already been pre-populated when the order was placed in PowerChart. And what would need to be completed is anything that's still highlighted yellow and has a red asterisk. So in this case, a referring provider, that is a required field. So we'll put a provider's name here, and whether or not an interpreter is required. For this example, I'm going to put no. And as we see, there are no other fields that need to be completed. If you do feel that there is something that does need to be filled out, such as the appointment reminder, this is where you would select it here. This is not a required field, but in the process of you scheduling with the patient, you'll be able to ask, would you like an appointment reminder? Yes or no. If it's yes, there is the option of selecting email, home phone, mobile phone, or via text. So once you select one of those yes answers, be sure to document either their phone number or their email address to ensure that they'll get that reminder. Any other questions before I move on? Once the accept format has been completed, we can click OK. And here is where our request now has landed in our work in progress window. That means that this request is now ready to be scheduled. You can either drag and drop the appointment onto the scheduling appointment book, or you can click on the suggest button. And in this case, sorry, it opened up a little weird. In this case, when you select suggest, the system will automatically suggest available appointment times. So if your patient states that they only want Wednesday appointments, you can make that determination by only have Wednesday highlighted. So when you click suggest, it will only give you Wednesday appointments. Otherwise, you can have everything selected, click suggest, and it will give you the next available appointments. So as I previously mentioned, all appointments have been built for 5 minutes for 5-minute intervals. So it can be booked every 5 minutes, 9:10, 9:15, 20, 25, 30, and so on and so forth. I'm going to go ahead and select a time. Once I pick a time, you see that a red check mark is now across that appointment, and that means that appointment has been selected and is ready for confirmation. When you come back to the scheduling appointment book, all of your books here are red. That means that appointment is now pending, and it's just now needs to be confirmed. We'll go ahead and click confirm. And once the appointment has been confirmed, you would get any patient preps listed here, as well as a summary of the appointment that was just scheduled. So here we have the date and time of the appointment, the duration, the appointment type, the location, as well as the name of the provider. At this point, if the patient requests a physical reminder of their appointment, you do have the option of printing out this document to hand to the patient. If there were preps or instructions for the patient, they would be listed here, and that will be available to the patient so they're aware what they need to do prior to their appointment. Click OK. And now that appointment has been confirmed. Any questions so far? No. Okay. So once the patient comes in for the day of their visit, you can come right to the appointment book to get them checked in. You'll find the patient that you would like to check in. I'm going to select this one, Caroline Cass Clinic, and I right click on it and it'll give me the options for actions. And I'm going to come down here and select check in. So I'll be brought to this check-in window, and just in the interest of time, I am just going to okay this particular encounter type, but typically you would update this appointment type to an outpatient encounter. I'm going to see if it's going to let me check it in using that, as I do see I might be running out of time. No, it's going to let me register as an outpatient. It is loading. Oh, here we go. So once you get to the register outpatient screen, be sure to fill out any required details. As I previously mentioned, anything that's highlighted yellow with a red asterisk within Cerner is a requirement, and you would not be able to move on to the next step until those items have been completed. So I'm just going to fill these out. As I mentioned before, in your education session, you will get a very detailed training on how to register a patient. I think that's all it's gonna require. Oh, no. Okay, let's try to complete. Still missing something. They don't have a health plan. Update that. Hopefully that's it. Next window will ask about the document selection, whether you need armbands, face sheets, blood specimen labels, all of that. I think we're going to go through those items later on in the presentation. But for now, I'm just going to get this patient checked in for us. And now you see that this patient is highlighted green. That's an indication that they have been checked in. And when you hover over it, that very last line indicates that they have been checked in, as opposed to an appointment that's still highlighted blue. It's only in a confirmed status. Any questions on the demo? Okay, I'm gonna hop back into our PowerPoint.
Hi, is it okay if we take like a quick 10-minute break?
Of course.
All right. Okay, I'll be right back.
Okay, not a problem.
Thank you.
Uh-huh. Okay, awesome. Let me share back my screen. Alrighty, can everyone see my screen. Okay, can everyone see my screen now?
Yes, we can.
Yep. Just to recap, we went through the scheduling demo from pulling the order off of the request queue and scheduling that and checking in the patient. Through that entire workflow, were there any issues, questions, or concerns before we hop into the last few slides of the scheduling presentation? Alrighty. So this next slide is a description of two sets of instructions that we have built into scheduling. We have guidelines and we have preps. The guidelines are used to instruct the scheduler on how to complete a particular scheduling workflow based on the responses selected in the scheduling accept format. The example that I have here, which does not necessarily apply to your clinic, but is just an example of one of the questions excuse me, one of the guidelines that we use. This one states that there were no answers entered into the appointment reminder field. So this is just a reminder, hey, the patient may want a reminder and there was nothing populated. So you may want to double back and fill that out before you continue with the scheduling process. So that's just an example. I don't recall that we had anything specific built for your clinic. So if you do think of any particular instructions that would be required to complete this scheduling workflow, please let me know and I can be sure to add that into the build. The other type of instruction is called a patient prep, which is any instructions that the clinic would like to communicate to the patient prior to their appointment. That can also be printed and handed to the patient if at the time of scheduling, if the patient is there in person. So this is an example of what I have actually for your clinic, indicating where the patient should show up and what they should do, and if they need to rebook, where they need to call. If there's anything above and beyond what we have listed here, please let me know. And again, those can be made those updates can be made to the build prior to our go live. Any questions on guidelines or patient preps? So the next slide is just an example of one of the reports that we use. This is called the patient itinerary report. This also is an indication that if the patient asks for an itinerary, which shows any appointment that they have scheduled across Richmond, this will also print the patient preps at the bottom of that document. So they'll have the instructions listed there as well. This is not for your clinic. This is just an example of the itinerary report and how it would look and the setup. So it will have the patient's appointments. It will have the patient's appointments listed at the top. That includes the date, the time, the appointment type, the provider, the duration, and where they're going to be seen. And then at the bottom, it will have all the listed preps for their various appointments. Next up, we do have some example of reports that are available within Cerner. I know we briefly touched on the pivot report, but these are the pivot report is available within Discern, while these reports are available right inside of the scheduling application. I'll show examples of a few of these before we get into the registration portion. So as I mentioned, this is what the person appointment itinerary looks like. It will display all appointments booked to a patient over a specified time period. Next up, we do have the schedule summary. Some clinics use this as their daily schedule if you feel that you need to have a printed out report. This is an example of what it will look like. It will have the appointments listed in order, in time order, and include the patient's name, as well as other demographic information, including their age, gender, and date of birth. This is a schedule by appointment type. This will list out all of the appointments based on the appointment type. So if there was a need to see only the appointments that are coming in for CAS new, that could be shown, or if you just want to see CAS follow-up, that could be shown as well. If that is needed, this is one of the reports that would be available to you. And finally, the single resource schedule. This will show you the schedule per provider. So if you only wanted to see Dr. Douglas's schedule, you would be able just to print out his schedule. But considering every day except Thursday, I think it is offhand, that you only have one provider per day, a report like this would only really be useful on the Thursday where you have two providers. And if you wanted to see a summary of the patients that only one particular provider was seeing versus the other, this is a type of report that you would use, the single resource, that you would only see that provider, that one provider schedule. Any questions on anything that we've seen so far within the scheduling app? Okay, well, that is it for me. Thank you, everyone. I think next up we have Tutu with the registration and labeling. Is she on the line?
Yes, I am. Kim,
Oh.
you want to put up the PowerPoint? Kim, I'm just going to speak to those slides.
Is this a slide you want to be on first?
Is that the first one? Just the first one. Oh, okay. Thank you so much. So, hello everyone. My name is Tutu from RSDQ. So we just have a few questions about labels. So at check-in, we have these two that print the armband label and the face sheet. And for as a default is checked, but this can be unchecked if any of this needs to be printed. So the question we want to ask today is, will any of these two be needed when a patient check-in for the appointment?
We will only require the face sheet. No armbands are printed for the CAS clinic.
Okay. Okay, noted. So one face sheet, no armband label. Okay. Thank you so much. And we can go to the next slide. Okay, so this is just showing all the labels that are available through registration conversation. So all these forms, all these labels can be printed. For example, the first one is patient form. And then these are all the informations that we have on that particular one. And these are usually needed for documents that requires scanning. And another example is external use labels, which is used for requisition. So all these labels are available through registration conversation, and this can be printed. Can you please go to the next slide? Thank you so much. So ad hoc printing for all positions. So, documents. So everyone have the ability to print off all these labels using this ad hoc printing. For this other one on this side is only, this can only be printed by clinicians, and they have the ability to print this using print labels conversation, and to make the process easier, the value can be set so that they have the specific type of labels with specific quantity. So we just want to know if any of these labels, will be printed. if the label conversation will be used. So, but then that question is for the clinicians. I'm not sure if there is anyone from the clinic here able to answer that question.
Yep, Ari here.
Okay.
So, upon registration at main admitting, we will need 6 external use labels. The other ones are rare used, so we will print it as needed.
Sorry, what did you say? What's the other one?
So the only one we need is the first one, the external use label, but we'll need 6 of them.
Okay, 6 copies, okay.
And then the other ones can just be like unchecked. Like, I don't know if you can make it a default that a face sheet, just 1 face sheet and 6 external use labels upon registration.
Okay, upon registration, okay. And do you know if any of these other labels will be used at the clinic? The blood specimen, lab none, patient form label, no?
The lab non-blood specimen labels are used, but it's very rare.
Okay.
So we would just print it on demand. And same with the patient form label on demand.
Oh, on demand. Okay, perfect. Okay. All right. Thank you so much. Yeah, that's all we need to know. Thank you so much.
Okay, so moving, any questions so far? It takes time as a no. So I'm going to move on to the day of visit. So the first thing I want to confirm is that wait while is no longer coming to the CAS clinic. Is that correct?
Correct.
Okay, so when it comes to monitoring where your patients are going to be, I know you currently use a paper printout. You can use that if you like. I'll also show you what we have for ambulatory organizer on or actually your SHAP book and how to print it out of SHAP book and how that will be seen for patients and also ambulatory organizer. So this is just an overview of the future state workflow. We're trying to emulate what you currently do with the role of Cora as the unit aid. So patient's going to come to the clinic or to the hospital, and they're going to be booked into registration as they currently are doing right now. And depending on whether the patient has an x-ray already booked in or they are going to be put directly into the waiting room or into the CAS clinic, the Cora will be the one managing that process. Are they going to be seen by you at all, Ari, at this point?
Usually they don't, unless they have questions for me.
Okay. So then the provider would then be the person who would see the patient next. So they'll do their assessment, their documentation, they'll enter any required requisitions, whether that be an x-ray or any lab work or ECG that's for surgery for a person who's going to either emergency surgery or who's going to be on the regular slate. The PT then sees a patient, they'll do their assessment, education, provide equipment, send the patient to next door to pay for the equipment and do documentation. So the provider is going to be the one who's entering the follow-up order. So I know previously Takami and Cora were helping out with that label system and that binder. Because Takami and Cora don't have registration capabilities through Cerner, it's not very standard for a unit clerk to, or sorry, a unit aide to have that capability. It's going to show up on RA's future request list. And it's really up to RA whether or not she wants to book that all at once at the end of the day or throughout the day, or if it's agreed upon that after they're seen by physio, that they send the patient over to RA to book the patient in for a follow-up appointment immediately after being seen by the PT. What do you think, RA?
So from a previous meeting, I believe that we were going to keep our current binder process where after they're seen by doctor and physio, doctor will decide, oh, they need to come back in 2 weeks. Then usually Cora or Takami will put a sticker on the date that they need to come back. So we will keep that for now, just while Cerner's starting off, and then we may change it so that they'll come see me at the desk afterwards. But just so no one is missed, we like to pre-book them and give them a date and time before they leave. And I'm not always at my desk. So
I see.
just so we don't miss anybody. Well, we're gonna keep that process until we get used to Cerner, and then we'll decide if I have the capacity to, book them on the fly.
Okay, I think that'll just come with practice. And so you mentioned that the patient should be booked for the follow-up before you leave, but then you may not be at your desk. So is that just going to be like that paper sheet that you're going to be writing down, like, oh, this patient's for follow-up?
Yeah, exactly.
Okay.
So their label will go on to the respective date that they need to return. And they're given a little slip of the date and time they need to come back.
Okay.
So, and like I said, usually Takami and Cora take care of this.
Okay. So, I mean, I don't see any problem with that. It's, we might as well show you also the other, when you guys are ready, how that process works as well.
Sure.
Okay. So I'll show that to you in a bit. I just wanted to mention that there are times, or it was noted that there are times the patient is identified to be seen or put on the emergency slate or to be seen by PAC. So at that point, I know you have these packages that are pre-made, so they'll still need to have their consent signed by paper and have the patient questionnaire also filled out by the patient as well on paper. But when it comes to the workflow of getting those patients on the emerge list or the regular slate, it'll follow the workflow of those respective areas. So Dr. Douglas, if he wants this patient for some reason to be booked for surgery immediately that day or the morning following, then he'll need to contact the OR desk, and all the med requisition, med rec review would be done on that encounter. So that's just some background information. It doesn't really affect you or Takami or Maggie. It's just kind of an overview about what happened in that workflow. Any questions about that? I guess the only thing is the doc would be the one who would be walking it over to the OR or PAC like they normally do.
Yep, sounds correct.
Okay, good. Okay, so Simone did show some of the different options for printing. So you can actually do this through your shop book. Hopefully it's not timing out. Okay, so this would be seen in this little print icon up here. There's a lot of different types that you can view it as. Simone had mentioned. And so for this one, for example, we'll load this up. Ambulatory and location is RHS gas clinic. And then let's say today's Friday, right? And you want to print this out for Monday, so you can have a copy for every person in the clinic. You can do so. So just put it for the 23rd. And then before you print, you could always view what it looks like. So let me just rotate it. So that's what it would look like. I believe it has all the information that you currently use in the example that you provided. So the time of the appointment, it's ordered by time, the patient's name, and then their demographic information. Okay, so that's done. What's next on the demo? Okay, so ambulatory organizer. So when it comes to ambulatory organizer, I just logged into the physiotherapist view, but it's going to be the same functionality for the fracture liaisoner, so Maggie here. So you can log on to see what the schedule is for the day. This is the alternative workflow that you can use if you're moving away from paper. And this way you can see when a patient has been checked in and recent for visit. So for Maggie, for example, if you looked at today's or the 20th schedule, you could look into these patients ahead of time, like you noted that you do, and you could always put in the notes that you want to see this patient so that that would communicate to the other clinicians that you want to see this patient. Any questions so far?
No.
No? Okay. So for Takami, I know probably the main functionality of Cerner that you'll be using is reviewing the charts or the past documentation. I'm gonna open. I think it just froze. Okay, so I think my demo just froze. Oh, perfect. It just shut down. Okay, perfect. So I did show you that last meeting, the auto text that we created for you. Is there anything new? And I pretty much just mirrored exactly what you had on there. Is there anything new for documentation? If you're speaking, there it's on mute.
Where do I chart from here?
So there's a couple ways you could go through the documentation and add it, or you could use like a quick note here. So this is just a quick note, visit summary. I think this is one that might be too basic for you, and so we did build out one for you. So we'll just do a free text note, just for example, it was PC, let's capitalize. It was this one here. So it was based on lower extremity, upper extremity, and it has like today's weight that will get filled in, and any other documentation that you want, it could be added to the additional notes.
Yeah, okay, yeah, that's the one I was looking for, yeah.
Okay, yeah, so that could be yours to use. If there's nothing else, we can always just continue with that one. I don't think you're gonna be ordering anything else. Like 3 quick orders, like you're not gonna be ordering, there's nothing else you'd be like ordering for the clinic.
Yeah, I wouldn't be ordering anything else. But in terms of the equipment stuff, are we still using the medical requisition, the supplies requisition, or is there something computer?
Oh, I think that's still gonna be the triplicate
Yeah.
that I know of. So I don't think that changed. That's going to be changing in the future.
Gotcha.
Okay, so yeah, so pretty much as it's the same as the last time I showed you documentation wise, like you'd be going through your actually just add. You'd be going through the documentation through here, reviewing, you could review what past visits that you've documented on this patient, or if you wanted to see their patient information, anything that you need to review the day of or during, you can do that through PowerChart. Okay. So we've already discussed work queue monitor. Okay, so auto text is done. So for Maggie, for you, you pretty much are searching out the resources that you need for the clinic. So I'm actually going to change into your view so that I can show you how you might be able to do that. So what I showed you last time was through Discern, and then you had a question as to whether or not you can click directly into that list of patients that were populated. And it was confirmed that you're not able to do that. You would just be copying and pasting the MRN into PowerChart. But I'll show you a different way of sorting out the patient lists so that you can just be in PowerChart already and click into that patient's chart directly. So for you, you could use the ambulatory organizer to see the patients for the next day, which is the 23rd. So I actually have to opt into the correct space here, sorry. So you could look to see ahead of time if you want to, at the end of your day, to see which patients and note which ones that you want to see after you open the chart and review the patient. And then you can add to chief complaint as well if there's anything else that you wanted to add to the patient's chart. So if it has something to do with their bone, a previous bone marrow, it's not bone marrow, bone density. I made the same error last time. Yeah. Yeah, so if there's anything from the last session and you've seen this patient before, you can always add that to your chief complaint. You could also go through patient, if you want to look for different patients in different units, you can go through patient list up top here, and you just set it to the location that you want to see. So creating a new one, you could do it by location, drop down to RHS. There's like a general RHS. No. So there's one for Richmond Hospital, and you can pick the specific units itself. And let's say 2 south, 3, 4 north, 6 north. Probably not 3 south. Maybe. Yeah, maybe. Merge is here as well. When it comes to loading it, it might be a little bit delayed, because if you're loading a lot of different units at the same time, but you can give it a go to see how it works. And
I can look at each one like separately, right?
You could, yeah, you could do that as well. And then you can collect these patients by making a patient list, but then you'd have to add them and remove them manually. So I know you have your own system when it comes to Excel, but you can definitely keep that that process as well.
But I'll be just a B, so I can pretty much see everybody and look at all their histories and blood works and all that stuff.
Yeah, exactly. So this would be an alternative method for looking at patients besides using Discern, which you won't be able to click directly into the chart.
And was this, I don't remember what Discern was, but was that from the slate from that day? What was Discern again?
I can actually show you a screenshot because it's pretty slow to load. So yes. So Discern is this application here. And then in the same way, you would be selecting the units that you'd want to view, and it'll show up just like so, but you're not able to click into the chart. In the future, that might change, but at this point, they haven't configured it for you to have that capability to click into the chart.
Thanks for showing me the other one.
What's that?
Thanks for showing me the other way, because that seems a bit more efficient.
Yeah, because that way you can look at their past the medications that they're on at home, if it's documented on their past medical history, their demographics. So all the information that you need, you can order it so that the top 4 components of the chart are just easy for you to use, and you can save your setting like so. Yep, so we've gone through that. Other than that, documentation wise, we reviewed the FLS documentation. Has that changed for you?
I don't think so, but there were some things like, I can't remember if I gave you guys the letters that I send out to patients, and after kind of meeting with my team, I think it's a good idea to put like our letters we send out to the patients with the actual like FLS heading, like Vancouver Coastal and FLS, and the ones we send to the doctors. Did I give you guys those letters? Because there's a bunch of them.
No, we didn't get any of those letters. So this would be sent to doctors, like their GP office?
Yeah, and the patients.
And
so
the
currently
patients.
my workflow is like I have it on my desktop or whatever, and I print it. And then I like handwrite the name and handwrite the diagnosis or whatever my recommendations are. It's like a standard letter, but obviously for each patient it's a little bit different. And then I mail it to the patient and then I fax it to the GP. So it'd be nice to have those on there that I can just like, I can autofill or whatever, put those things in rather than me having to print it and then get it from the printer and then handwrite, you know, and just be able to do it a little bit more efficiently.
So for the CST team, is there a way to do that through Cerner, email wise? For the patient specifically?
Yeah, it doesn't need to be to the, I don't have to email to the patient, but just to get it, like, right now I'm pulling it off like Google Drive, and then I have to like print it, and I gotta handwrite everything, and then I gotta like, I don't mind, I just want it to have like the heading, have Bank of the Coastal, have like an official document as opposed to me just doing it.
Yeah, it's Dolores. So we can do it via like FormFast. So we can create these patient forms, have them on FormFast. You can print them. It'll auto-populate like patient demographics and things like that. But FormFast isn't unfortunately like a fillable form. So you would still need to do parts of it manually and manually fill it in. But we could at least have, you know, demographics and some other things like auto-populate from that form as a starting point. The alternative would be to, if you have these forms, are the forms you have currently, are they fillable forms on PDF, like Adobe PDF?
They're currently Word documents.
Okay.
I could make them be like, I could do that, but
yeah, so that's another option, right? Is you could potentially convert them over to fillable PDFs and then just keep them sort of off system. But we could add them to FormFast as a like a starting point. If you wanted to send us all of those forms, we could have a look and we could see what we have. And are these forms kind of standard forms that like your clinic sends, but as like other clinics as well, like other CAS clinics, are they similar? Because we might have, if they're similar, we might have something already on FormFast.
no, because I'm the first one in the still to have this.
Okay.
And so they're forms that us other FLSers and like Fraser's have, but it's they're unique. Like ours are a little bit different from theirs, so it's unique to us.
Okay, so yeah, so why don't you send them over to Kim, and then we can have a look and see what's already on FormFast. There might be something already on there, but if not, we can put what we can on FormFast, and then we can let you know if there's certain like forms that won't be able to go on there. But I think, Kim, that would be the best option for those forms.
Thanks, Loris. Question for Maggie. So this is your documentation. So if you're wanting to send some information to the provider, does it include all of this information plus more?
Well, I don't send that to the GP, but if I'm gonna do a healthy bones referral, then I usually I send that to them as well because it gives them a lot of the information. So it depends. Like usually to the GPs, I send blood work and it's one of the standard letters to say and some information that the patient's high risk or moderate risk or whatever. But this form, sometimes I do send.
Okay, so I'm wondering if you could use the message center. Communicate button. Let me just put it in the context of the patient to communicate this with other providers. So we're using this patient as an example and we want to communicate to a doc. So it's in the context of this patient. And then you could send it to the provider this way. And just correct me if it's wrong, like GPs we're able to send GPs emails through this function. Yes, you do.
Thanks for asking me. I currently don't send anything email, just so you know, Kim. I just
okay, I see.
I mean, it'd be great if I could, it'd be so much faster, but right now it's through fax, so I don't have any GP's emails. But even like when I send to Healthy Bones, everything's through fax. And so the providers, I don't know anything.
So I'm wondering, can someone, does someone know if the GPE, if we look up the GP's name, that their email is going to be loaded onto this, or if it's just Cerner sites?
It's Dolores again. Yeah, I think it's just Cerner sites. But the idea is to eventually start adding all these GPs and things like that. So they might have like some pharmacies already preloaded that you can kind of select from and other things. But I do believe that the contacts, like the email addresses and stuff, is mostly Cerner sites. Is anyone else on the team? Does anyone else have any other information? But I think it's just Cerner sites.
Yeah, I know that we load the College of Physicians doctors list, but I don't think it extends to their email addresses.
Okay, so then scrap that idea.
Yeah, I'll look into it. I know we pull from that database, and the other issue is it's often out of date because the doctors themselves don't often update their information when they move and make changes to their locations or their practices. So even that's problematic. But it was a question that came up with BC Cancer. And I'll go find the ticket because I'm pretty sure that there was another resource found. So maybe we've changed how we do it, but I know it wasn't up to date with email addresses in the past.
Okay.
Outside of Cerner. The Cerner ones, I think, are quite up to date.
Sorry, Kim, can I ask something? Or
yeah, go
so
for it.
I know that on Cerner, from people who use it, that you can make a template, because these letters that I send out, we're always kind of updating and changing not just the patient's demographics, but some of the information, like the type of fracture, or if we have to change, like because of their BMD results or something. So is a template possible for these letters?
You can make a template on Cerner, but the idea of making a template is for the document to document into the patient's chart.
Yeah, that's what the letters will be in the chart. So I'm okay with that.
Okay, yeah, so right now I just have this one that you provided us. If there's anything else, send that my way and we can,
there's
a create that
bunch, because they're all unique. Like there's like low, moderate, high. There's just a whole bunch, and there's some in different languages and stuff. So,
and so this is going to be sent to a Cerner doctor, or
no, this is being sent to all the GPs. So once I kind of figure out what the patient's risk is, either low, moderate, high, I always send the GP. I fax the GP. I'm only faxing to the GPs. I fax them what their risk is. And I print their blood work from PCIS, and then I print these letters that I send to the GP, and then I print a fax cover form, and then I fax it. And then there's also patient letters that I mail to them to say whether they're low, moderate, high, but they're always a little bit unique to the patient. But so that's why if we can get a template, I think we can kind of make it precise to that patient.
yeah, I mean, if the intention is to put it in the chart, then that would make sense to put it in this template. But then to get it to the provider that's not on Cerner, I don't think that's how it works.
But can I just print it and then like I can?
Oh, I see.
Like I'll still print it, but at least it'll have all that information kind of there.
Okay, so then if we make a template, it'll be on the patient's chart, plus you could print it. Yes. That's possible.
I'll email all of those things.
Great. And can you also email what you would want it called?
Maybe special forms. Okay.
I guess I'll call it FF. No, for each one, like moderate, FF, moderate. Okay, great. Perfect. So that I believe is the end. So Maggie, is there anything else? Because for you, you're not really ordering anything. You're not really you're just reviewing the patients that are coming in through ambulatory organizer and using that patient list to kind of search out patients on different units. Is there anything else that you need Cerner wise?
Yeah, well, yes, because I don't know if you remember, I said I do order BMDs externally, so the bone densities external. And then a point was brought up, like I get the results, so, and that gets faxed to me. So then those need to be somehow uploaded, right, to Cerner. So how does that happen?
So for orders that are external, I don't believe that that's going to be on Cerner if it's going to be like a specialized clinic. So that would still be your regular paper referral process.
No, but when I get the results, so then they fax me the results back, like after the patient has the x-ray. So that should be part of their file, their chart, yeah.
So it'd be faxed to your work queue monitor, and it would then need to be indexed into the patient's chart. So that would be RA who might see it.
So we will learn how to do that.
You don't have the capability of actually someone.
Oh, that's fine. Like she can do it, but just as long as she knows how, like, because you're gonna have to eventually fax or put things, scan things in the charts. I guess the BMDs. I'm just looking at her while I'm talking to her, but you'll have to put that in. Okay.
I mean, the alternative is if you want it on the patient's chart, you would send it to records, and they would be the ones to scan it into the patient's chart. That's the alternative to save RA.
And also, sorry, Kim, so like I know that you guys, because I'm in the CAS clinic, you lump me in the CAS clinic, but FLS is its own separate identity. So when I send these letters and I send things, will it say there, like, I don't want it to say CAS clinic, it should be identifying this as FLS. Is that possible?
So the things that are printed out, I wonder, I think it's gonna say your role. I don't think it's going to say CAS clinic. So this is just a random note that I picked out, and that's just the name of the note and then your role. I don't think it's going to say CAS clinic.
Like even on the letters, like the templates or whatever prints, I assume that like those will say like Vancouver Coastal, because currently the ones I use say Vancouver Coastal, but it won't be connected to, it won't say like subsection or something, CAS clinic. It'll be, is it possible for it to say FLS somewhere in there?
Through the template, no, unless you add on your template FLS nurse, and then we can put your name on there, but you could put that manually as well. But when it comes to like having like the VCH emblem and all that stuff, it's not going to look exactly like what you have in paper form that you have. It's going to look a little bit more, what's the word? This is very basic. It's not going to be like perfectly formatted, because if you look at the documentation, I don't know if I have anything for this patient. That's
a good way of putting it there, Kim. It's going to look basic.
Yeah. It's just, oh no. So there's nothing really detailed here except for people putting test. So it could, I mean, it could be organized like this, but it's not going to look as pretty as it would normally look like on your current paper that you do it on.
No, it doesn't look pretty anymore. So I guess just curious, because you know how like VCH has all these rules with their like emblem or whatever, their logo, and you can only, you know, like 6 inches from the top and all that stuff. So does Cerner print anything, period, for VCH? And does it follow all those rules? Because the colors have to be a certain thing for the logo and all that stuff. Like, is there, you know, because people still have to print stuff from Cerner.
I think if you want to maintain what it looks like, as Dolores mentioned, form pass would be the way to go. But then you'd have to manually write it in, or use the PDF function where you autofill it in PDF and then print it out that way. But then it won't be part of the chart, I believe. So I'm just trying to think this out too.
I'll send you these anyways.
Yeah, I was just gonna say, the FormFast stuff though can be printed like back, or sorry, scanned back into the chart. So HIM can scan it back in, like afterwards.
That would be a nice version.
So a couple options. You could either do it through the template, but visually wise, if you want to use the same format that you're currently using, yeah, FormFast would be the way to go. And then yes, as Dolores said, you can put it back into the chart. Yeah, you collect these papers and send it to records or HIM to put it manually into the system scanned. It's really up to you.
Okay, thanks. I think that's it for now.
Okay. Yeah, think about it. Yeah, or in case there's something else that you wanted on there as well. I'm just an email away. So. Okay, is there any questions for this meeting for anybody on scheduling or informatics? I'm going to take that silence as a no. So that concludes our session for today.
Thank you so much.
Bye, everyone.
Thank you. Bye.
Thanks, Kim. Thanks, everyone. Bye.
Bye.
Everyone.